It's a little undaunting to get up here after Peter Cotton. So, first of all, I think we need to give Dave and his group a hand for setting up such a fabulous meeting. So let's do that. Second, I think chronic pancreatitis has kind of taken second fiddle to pancreatic cancer recently. And if you think, when is the last time there's been a symposium like this on chronic pancreatitis? It's been too long, so again, well done, okay? Now I'm gonna take the prerogative and talk about something that I read about rather than lived. Peter's talked about something he lived through. I'm gonna tell you what I read about prior to starting my career. And I'm gonna talk specifically about surgery of chronic pancreatitis in the modern age. And it's going to start not in 1960, but in 1940. And this is my interpretation. If you want to argue with me, I'm more than happy to participate in this. But I'm going to tell you how I look on the development of what we do today. And I'm not going to talk much about 1980 on, because that's what this conference is about. So let's get going. So I'm going to talk about post-1940 chronic pancreatitis surgery. So when we think about it, I think about pancreatic denervation, subtotal creeping resections from the left to the right, ductal drainage, total pancreatectomy. We're going to talk about the pacemaker of pain of chronic pancreatitis. Not too much about splanchnic neurectomy, a little bit about pancreatic preserving resections. And then my colleague who follows, Jeff, is going to talk about the history of autoislet transplant. So when we think about it, there are a lot of big names. Unfortunately, most of these people are not still alive. Mallet Guy in France, a whole group of people that were interested in creeping resections from the left to the right. The ductal drainage people, and I'm going to talk about each of these guys very briefly. The people who talked and worked on total pancreatectomy for chronic pancreatitis. We'll talk about a little bit about Longmire and Bager with the pacemaker. And I look at the development really along these lines. The first decade, 1940 to 1950, was pretty much the decade of pancreatic denervation. The 50s, 60s, and 70s were the ductal drainage procedures and the distal-based resections, 60 to 80 to 95% to total pancreatectomy. And then really the modern era, I think in what we're going to talk about, came with the concept of proximal-based resections. A little bit of work on thoracoscopic splanchnosectomy. We might ask Flip Borman to talk a little bit about that. He's been interested in it. The pancreas preserving resections, and then the current era of autoislet transplantation. Now, if you think about it, it's 1940. What are the influences in determining what you do? Well, the modern era of pancreatectomy really started in the 1940s. Yes, there were people doing pancreatectomies before that, but think of the morbidity and the mortality of a pancreatic resection in 1940. We had no good critical care. Blood bank was not good. People were malnourished. We didn't have a way to resuscitate them from a nutritional standpoint, and there was no cross-sectional imaging. Think about it. We couldn't diagnose ductal dilation before that. Yes, we could see calcification of the pancreas, but we really couldn't see much more detail. And we didn't really know what the type of inflammation was. And this is a statement in 1903 that I think summarizes the state of the art really even in the 1940s. But this was in 1903. The cause of the tardy development of the surgery of the pancreas was really three reasons. One, the topographical relations of the organ, the difficulty in diagnosis, and the operation, quote, is more dangerous than an operation upon any other abdominal organ. Well, that's changed now. But in 1940, this was still pertinent. So let's start with autonomic neurectomy. pretty much pioneered by Mallet Guy and Deitakis. I always thought the concept was that you did a neurectomy, excuse me, to stop pain. But when you read Mallet Guy's work, it was also to stop the recurrent, relapsing episodes of pancreatitis. And he did a visceral neurectomy, approach from the flank, with no resection, little bit of morbidity, little mortality, and it was much safer than taking out the pancreas. The thoracoscopic splanchnosectomies came on with our minimal access techniques, a huge interest in, and that's probably pretty much waned out now. Now, here is his last paper that I could find, and I purposely put the last one rather than the first one. Notice this was published in 1983, and he did most of his work in the 1940s and early 1950s. And he followed up 216 patients. He had chronic 34-year follow-up. And when you read the paper, it's very interesting because he claims pretty good results. This led to the interest in thoracoscopic splanchnosectomies through a minimal access approach. Huge interest that's kind of waned off now. But that really went by the wayside when the concept of ductal drainage came. And the concept behind this is a dilated pancreatic duct suggests obstruction. Obstruction is believed to cause pain. And if you drain the duct, you'll relieve pain. It's safer than a resection because you don't have to do the dissection, and you preserve pancreatic parenchyma. And at least I want to point out much of this work was done in the VA system in the 50s and the 60s, and if you think about it, there are a lot of alcoholics in the VA system. A lot of this started by the work of a guy named Link back in 1911, where he had a young female with chronic pancreatitis, a dilated duct. He dissected out the pancreas, the body and tail of the pancreas, flipped it through the mesocolon, put a tube in it, and brought it out the abdomen. That was the original ductal drainage procedure. Not much happened after that until Duval in the Bronx, again in a VA system, said, well, why don't we drain the pancreas by doing a limited distal pancreatectomy and bringing up a roux limb. This is in 1954. Most of these series are small series of 6 to 8 patients. Well, then Pusteaux said, well, we know that the duct is dilated. There are multiple obstructions in it. Why don't we open up the entire duct? So he and Gillespie would do a distal pancreatectomy with splenectomy and then use that to find the duct and fillet it open. Those of you that are surgeons in the room, look where the roux limb was brought. It was brought to the left of the middle colic vessels, not to the right. Little known is that they also did pancreatogastrostomies after a Pusteaux procedure. Has anybody in the audience ever done that? Yeah. Have you? I've never seen that. Well, then Partington and Rochelle in Cleveland said, well, why do we have to do a distal pancreatectomy and a splenectomy? There's morbidity that goes into that. The dissection can be difficult. Why don't we just fillet open the duct? And they did that without a distal pancreatectomy, without a splenectomy. And note where the roux limb goes in this time. It's to the right of the middle colic vessels. And of course, this work was the foundation that led Fry to describe the Fry procedure, where the duct is open, but instead of just opening up the duct, you would core out the head. I think he did it primarily because it was difficult to get the head of the gland drained with just filleting the duct because it dives posteriorly. He probably also was privy to some of the work by others as well, like Longmire and like Bager, where they talked about the head being the pacemaker of the gland. And there's even some experimental work to support this concept, because Reber did a lot of work in cats, and he showed that the chronic pancreatitis was associated with decreased blood flow, fibrosis, and increased ductal and importantly, parenchymal pressure. And he described a compartment syndrome of the pancreas that leads further support to the work by Fry. But what do you do with pancreatic disease that doesn't have a dilated duct? Well, my review of this is that people in the 50s and 60s felt that the amount of pain was directly related to the amount of gland involved. And it was safer to start from the left and proceed to the right because you didn't have to do any bilioenteric anastomoses, you didn't have to resect the duodenum. So the greater the resection, the greater the pain relief. It's safer to proceed from a distal pancreatectomy to a proximal pancreatectomy. And as a medical student, I read all these papers. Brash, Warren, Jordan, Whipple, Claggett, Brooks, Child, Longmire, Fry, White, Thomas Taylor White, big tall guy, his feet about this long, Cattell. Unfortunately, not many of these people are still alive. The Leahy, the Brigham, Houston, Michigan, Seattle, Mayo, Germany, France, etc. The problem is the results were inconsistent. Diabetes was a common complication, and of course exocrine insufficiency was exacerbated by these resections. Remember, most of these people were non-compliant alcoholics. Well, then this concept of the pacemaker of the gland came, and I think I'd be interested if anybody knows who really published the word pacemaker first, because I've tried to find it in Longmire's work. When you talk to Bill Traverso, he says, he used the term all the time. The word pacemaker to me comes from Longmire. Whoops. But we need to be fair to Hans Bager as well, because Bager described what most people think is a ductal drainage procedure, but it was a relatively limited anatomic resection of the head of the gland with drainage of the duct distally. And then, of course, the work of Longmire with pylorus preservation, but this was in the setting of a proximal pancreatectomy, and that is to remove the head of the gland, at least in theory where the pacemaker is. And there's quite a bit of Japanese physiologic data that the pain of the pancreas comes from nerves going to the head of the gland. That never really caught on. Well, finally, what about pancreatic islet cell autotransplantation? The idea was if you can do this, you preserve glucose tolerance, you avoid brittle diabetes. It started with the whole organ transplants, the concept of collagenase dispersion, Ficot gradients, taking the pancreas, chopping it up, and forming a slurry. I participated in a little bit of that. And then giving this slurry, not isolated islets, back to the patients. And then, of course, all the work recently with Sutherland, Lacey, Nigerian, Sharp, many others that developed the techniques of islet cell transplantation, which you're going to hear from the next speaker. So this is my concept of the history of surgery for chronic pancreatitis in the modern era. I'd be interested in any questions. Thanks.